Hello, thank you for joining us today. I see people are entering from the waiting room. It's wonderful to have you here um, for our topic, substance use disorder, affordable treatment on your employees' terms. We're very pleased to bring this to you with in partnership with Boulder, excuse me. Um, so it's we've got a packed hour, lots of information to bring your way. Let's go to the next slide. Thank you. So I am Denise Giambalvo, Director of Member Engagement and Business Strategy here at the Washington Health Alliance. And we'll be talking about why we're here, right? Why is this an important topic for us to be discussing now? And Sarah Young will introduce that to you. She's with Boulder Care. And then we'll move into recognizing the signs of substance use disorder. What should you be looking for? With Dr. Amy Potter to lead that discussion and review with us what's working in the market. And then we'll open it up for Q&A. You don't have to wait to enter your questions. At any time during the program, you can enter through the Q&A. Let's go to next slide. Talk about how you are all muted. But that doesn't prevent you from asking us questions. We will provide the presentation and the recording after the day is done. And there are some really wonderful resources that you can access through Boulder Care. Not just about Boulder Care, but also many patient resources that I think as benefits buyers, you'll find valuable, even for your own knowledge. Next. So, the value of being a member at Washington Health Alliance. First and foremost, we're a trusted convener in the state of Washington. We've built that trust over 20 years, and it really allows us to broach the difficult discussions and ask the difficult questions that purchasers have on their minds, and even our providers and health plans. So we are multi-stakeholder, bring everyone together, and we are very well positioned for moving the market to what's in the best interest for our purchasers and the workforce. And so education like we're providing today, there's more to look forward to this year with the release of our community checkup coming up on January 30th. Let's move to next slide. Menopause in the workplace. So overcoming that stigma. We're hearing much more, right, about menopause. More and more people are talking about it. We want to see that discussion continue, and we will bring education to you about menopause and provide you with tools and resources to help you as employers to facilitate those discussions and take a look at your benefits to see how you're supporting those experiencing menopause at the workplace. 2 one-day events in person planned this year. There will be a virtual option, but our primary focus is to get everyone together in person. So pharmacy benefits, right? Getting to the real price. What is that? And that we currently have it planned for April 17th. I anticipate that date moving soon to May 15th because there's a report that some of our employers have submitted their data to to be a part of this report. It's Washington State Pharmacy Association that's sponsoring this. So we have pharmacies around the state who have sent their data to be a part of this analysis. And we'll see what it all reveals, what's happening in how claims are being adjudicated, who's paying what, where. And so much more to come on that, but I would mark your calendars. Again, May 15th is the date that we're looking at now to move this, primarily because we want to make sure the report is included in this education event. And you'll be receiving much information about what to look for when you're shopping for PBMs and conversations to have with those that you currently contract with. Healthcare, if you spend more, are you going to get better? That's our big question, right? Show up on June 6th to find out, and also to learn about the outcome of our report on hospital price transparency. We'll have that available on June 6th. And taking a look at how the commercial market, or what the commercial market is paying in Washington for care at hospitals. So as a percent of Medicare, what does that look like? And then many other things, right? So we're doing work on equity around primary care and aligning with the state on advancing primary care, and the advanced primary care model, right? So aligning with that and helping to move the market closer to that model for across providers. And then, at the heart of our reports and informing our work is quality improvement, our health economics, always engaging with our purchasers in a closed forum on a quarterly basis, but then also bringing education like this to all of you. And as I mentioned, hospital price transparency is a big important topic for us to be covering in 2024. Let's move forward. Yeah, so we've got a poll for you. Seeing that there we go. Awesome. Thank you, Teresa. So which of the following, no, not the poll that we want. Can you go back? So here we go. So what percentage of adults in the US living with a substance use disorder are in the workforce? So you should be able to just click on your screen. Yep. Seeing results coming in now. And then all over, we've got 25% is winning at the moment. Okay. So let's reveal the final. So the majority think 25%, so half of you, right? And then the rest is somewhat evenly distributed, with 75% coming in next. We will reveal the answer to that shortly. So we turn this over to Sarah Young, Vice President, Partnerships at Boulder Care. And Sarah will tell you what that correct answer is.
Thank you so much, Denise. And I promise we'll get there, but not right away. Hang in there for about 10 minutes. Good afternoon, everyone. I'm Sarah Young. and I lead partnerships at Boulder Care. For those of you who don't know about Boulder Care, we're a telemedicine provider of addiction treatment for people living with some of the most common substance use disorders. My team and I spend time building partnerships with payers, Medicaid and commercial markets, including plan sponsors, with hospitals, and with community-based organizations that are largely focused on harm reduction and recovery in all the communities that we serve. Washington State and the Pacific Northwest generally is where Boulder Care has its roots. And I'm so glad to be spending time with this audience today. Very briefly, prior to joining Boulder Care back in 2021, I led client success efforts at Teladoc, and before that, Livongo, and before that, Castlight Health. So I've worked in healthcare for a little over 20 years, and I honestly can't imagine a more fascinating and relevant industry than this one. So over the next 10 minutes, my goal is to orient you to the landscape of substance use disorder, starting with national and then focusing on Washington State specifically. Let's get started. Next slide, please. So as we start to talk about substance use disorder, it can be really helpful to size the problem. And we're fortunate, we have annual estimates from the Substance Abuse and Mental Health Services Administration. You might hear me refer to this agency as SAMHSA. It's kind of a mouthful. It's the federal agency that's primarily responsible for supporting community-based mental health and substance abuse treatment and prevention services. And it's located within the Department of Health and Human Services. According to SAMHSA's latest national report, which was issued at the end of last year on drug use and health, over 48 million Americans aged 12 and older are living with a substance use disorder. Many of them, nearly 30 million, are living with alcohol use disorder, and over 6 million are living with opioid use disorder. Those are the two conditions that Boulder Care is devoted to treating. For comparison, the NIH estimates about 37 million Americans, or 1 in 10, are living with diabetes. So substance use disorder is a really big problem. Next slide. So who are all these people living with substance use disorder? That was a big number, 48 million. They are our neighbors, no matter where we live. And they are our coworkers, no matter where we work. They're people who are living with a chronic condition in a country where nearly half of adults live with at least one chronic condition. Dr. Potter will talk more about this in her section about understanding addiction, but it's worth saying really early in our time together that the view that addiction is a sickness, a lack of willpower, or a moral failing has been largely replaced by the position that drug addiction is a disease. And the overwhelming majority of medical professionals and addiction experts agree that it is a disease, it affects the brain, and it requires professional treatment. So I want you to take away with you as we go through the rest of this that SUD impacts people from all walks of life, pursuing all types of work. Next slide, please. Okay, so we've established that substance use disorder, or SUD, is a really big problem, impacting millions of people from all walks of life. Could you go back a slide, please? I think we might have skipped one over. Oh, perhaps not. No worries. It's also a growing problem, and it's one that deserves the time and attention you're giving it today. We'll focus on opioid use disorder for the moment. So SAMHSA completes that national report on drug use and health annually. They've done that since 1971. And that report provides nationally representative data on use of tobacco, alcohol, and drugs, on substance use disorders and receipt of treatment, on mental health issues and use of services for mental health. And that survey is about the civilian non-institutionalized population, age 12 and older. What you will find if you chart the percent of people with opioid use disorder, as it was reported in each of those annual reports, is that the prevalence has grown markedly post-2019. And you're going to see some Washington-specific charts on just how it's grown in Washington. And sadly, treatment's not keeping pace with this growing need. In 2022, only 1 in 4 people living with a substance use disorder received any treatment for it. You can see the rates vary by age group. Young adults between 18 to 25 receive treatment at the lowest rate. Those are our youngest workers. And at the other end of the spectrum, adolescents between the ages of 12 and 17 receive treatment at the highest rate. Even in that group, over half the people in need received no treatment. Let's take a minute to talk about Washington specifically. Can advance to the next slide. Oh, okay. And one more. Here we go. In Washington, we observe a similar trend with respect to overdose. So drug poisonings have increased markedly since 2019. We see the impact of this worsening opioid epidemic on the very youngest people in Washington. Almost 1% of hospital births are cases of neonatal opioid withdrawal syndrome. We also see the impact on first responders who were called to suspected opioid-related overdoses more than 2,000 times a month in 2023. Turning attention to alcohol use disorder, Washington averages 1 death from excessive alcohol use for every 2,420 people aged 18 and older. That's 5.28 deaths per 10,000 adults. For context, because that might not be familiar to you, for context, Utah is the state with the lowest rate of alcohol-related deaths at 3.9 per 10,000 adults, and New Mexico has the highest rate at 10 per 10,000 adults. According to the National Center for Drug Abuse Statistics, Washington taxpayers spent $3 per drink in 2022 on the cost to the state of excessive alcohol use. You can go to the next slide. Those rates of drug poisonings that increased so much in recent years, they don't impact all Washingtonians equally. And you can see that here. The overdose death rate for American Indian and Alaska Native people, it's historically been much higher than other groups. You can see that here, but the gap has widened considerably in the last 3 years for that group. Similarly, the Black community has an opioid overdose death rate 2 times the rate of multiple races, which is represented in that blue line. If you happen to read the December publication from the Washington governor's office, in which Governor Inslee previewed his budget strategy to take down fentanyl, you'll have seen this chart already. To support efforts among those tribal communities, Governor Inslee's proposed funding deployment of 2 programs, the Icelandic Prevention Model and the Rise Above program, both of which are models or programs that treat substance use as a social problem rather than an individual problem. Next slide, please. Okay, so where do plan sponsors fit in this problem? Plan sponsors know that SUD is costly when it goes untreated, and most people go untreated. Plan sponsors know that SUD is costly when it's treated with the wrong level of care. So that's the information in the center of the slide there. Dr. Potter will talk about the evolution of SUD treatment, the availability of outpatient options that are more accessible more appropriate clinically, and more cost-effective than traditional inpatient and residential options. And finally, plan sponsors deserve to know that treating SUD with FDA-approved medications works. Medication reduces overdose risk by 70%. It keeps people alive so they have a chance at recovery when they're ready. Medication reduces opioid-related and all-cause hospitalizations, saving money for plan sponsors. And sadly, medication is not offered in most treatment settings. As plan sponsors, you should be equipped with knowledge about the benefits of medication for addiction and evaluating treatment options for your plan through that lens. Next slide, please. Here we go. I will give you the answer, the initial polling question. So going back to that initial polling question, we know 75% of adults living with substance use disorder in this country are in the workforce. The annual cost of substance use disorder to employers is estimated at over $600 billion. Furthermore, looking at the data on the left, when you provide and employees receive effective treatment for substance use disorder, they miss less work than the general workforce. Just one more compelling reason to pay attention to this right now. So what can plan sponsors do to make effective treatment options available to their workforce and less stigmatizing for their workforce? I'm going to pass the mic to Dr. Potter to talk about how do you recognize substance use disorder as a first step, after which we'll talk together about what's getting better in SUD care.
Hi, folks. Thanks so much for advancing the slide. My name is Amy Potter. I'm a family medicine physician. I work at Boulder Care. I am the associate medical director there. I also have Washington roots as well. I trained in Seattle for my family medicine residency at Swedish Cherry Hill. So feel kindred spirits on the video today, even if I can't see your faces. So I'd like to talk a little bit more about understanding substance use disorder. And I think I can't put this slide up here without saying, you know, what goes in hand with substance use disorder is also stigma and a lot of misunderstanding and misinformation about it. So, you know, knowing that we have a wide variety of folks in this audience today, I'm going to go through some kind of basic terms. And I start here not to do it like too simple of a level, but to make sure that we all have those basic blocks of understanding. And I think then the language to be able to talk about this with our teams as well, without any assumption that anybody has a medical degree or any level of training behind it. So we want to start thinking about addiction from a really fundamental level of understanding what it is so that we can try to destigmatize it and appropriately navigate folks to resources. So, you know, there's a lot of misunderstanding between words, specifically like dependence, tolerance, and addiction. So I thought we'd kind of start there today to talk about what are the difference between those terms. So addiction really refers to the idea of engaging in some sort of risky or unsafe behavior, whether that's to yourself, the person struggling with the use disorder, or others, in order to continue using or accessing that substance. And that addiction piece does not require dependence or tolerance to that substance. So a lot of times I think we assume that these are a package deal, but we really have to kind of parse these terms out and understand what's actually happening for somebody. So I'll kind of flip that around and say, on the other hand, let's think about dependence for a moment. So I think a lot of us can really identify probably with the term dependence. And I will be the first to raise my hand and say, I am a coffee drinker. And so I have somewhat of a dependence on coffee in the sense that it is something I really rely on in the mornings. It really wakes me up. It gets my day started. It actually makes me feel positive and get things going. But on the other hand, I'm not addicted in the sense that if I weren't able to access my coffee that morning, I might be bummed, maybe a little bit grumpy because I might have a few physical dependent symptoms reliant on that coffee, like people develop a headache, or maybe say they're a little cranky when they don't get their coffee. But I'm not necessarily doing something risky to myself or to my coworkers in order to access my first cup of coffee. So that's a way of thinking about dependence. On the flip side, folks can have an addiction to something without actually demonstrating those signs of physical dependence that we think of when we talk about those coffee drinkers getting the headache if they miss their first dose of the day. So I just wanted to start there with kind of parsing out those terms. And then the last one to think about is the word tolerance. And that basically means if you were a coffee drinker and you used to feel good after one cup, but after, I don't know, a couple years of drinking one cup in the morning, you notice, you know what, it doesn't really perk me up. It doesn't give me that good mood it used to. So you bump it up to 2 a day. That might demonstrate that, again, you have a tolerance to that caffeine, to that substance. But again, if it's not accompanied by those risky or unsafe behaviors or behavior changes, then we wouldn't label it an addiction. But I don't want to judge people and their coffee. It could get there. So you can go ahead and advance. So you can go ahead and pop through. Perfect. I was going to say, pull up all those bullet points for me. So right along with the word addiction, we get the word stigma and lots of misconceptions. So I want to talk through a couple of ideas around this disease. And I really appreciate how Sarah introduced that and kind of planted that seed with us all in the introductory section. So addiction is not simply a brain disease. It's not like we can identify one place in the brain where we say, hey, if we could just flip that switch, this would be solved. In fact, addiction is a complex, what I would say, multifactorial disease. And so we know at a fundamental level that we're talking often about what happens at a receptor. When we're talking about dependence or tolerance, we know that that's happening at a receptor level in the body. But the behavior change and the patterns that surround that receptor behavior is much more complex than just saying, I'm flipping a switch on and off, and is often, complex because of the surroundings that that person is in. There are many factors that contribute to the development of this disease. And in my experience with each patient, it's usually a different combination of factors that has to do with their physical setup and those receptors in their body, but is also impacted by their psychosocial experience of life. Another misconception, which I think I already touched on in the previous slide, is that this is all just about a physical dependence on the substance. Folks can, in fact, be dependent on a substance without addiction. And we like to point this out because, opioids obviously have gotten a reputation in the past few years. But at the same time, there are folks out there who are appropriately prescribed opioid medications for conditions that require that, and who never develop that piece that we consider addiction because their behavior around the use of that prescribed medication never changes, never becomes risky, never becomes unsafe. So you can be physically dependent on a substance, but not necessarily have that addiction behavior attached to it. Along those lines, addiction is not just about cravings. Folks who may be physically dependent but not have an addiction may experience cravings for a substance if they don't have access to it. By the same token, we have a lot of labels out there and lots of misconception about anybody who develops a tolerance to medication automatically has an addiction. And I think I've probably said this a couple of times, but that connection is not necessary. And folks with an increased tolerance to some substance, whether it be a prescribed one or a non-prescribed, may in fact not have an addiction if their behavior never changes around that use. And then I actually like this bullet point because it kind of speaks back to our poll that we did a few minutes ago, which is this idea that you can't have an addiction until you've hit rock bottom. And I have this conversation with a lot of folks around alcohol and folks whose pattern of alcohol use is disordered. But they say, hey, I'm working, I've got kids, I'm carrying a job, my life is together. And it doesn't require your life to be falling apart to actually have a substance use disorder. You don't have to have hit rock bottom to have a substance impacting your life and your function. And then Sarah mentioned this is really important to us at Boulder Care, but we work day in and day out to talk about the fact that addiction is not a moral failing. Unfortunately, the label of addiction in our society does carry a significant amount of judgment and stigma for our patients. And so, we just like to talk about that at every single opportunity and remind folks throughout our healthcare system and also our partners that we work with that these are human beings. They are struggling with a disease in the same way that when I talk to folks about managing their hypertension or their diabetes, those folks are struggling to manage their disease. And so if we can work all together to talk openly about these diseases, talk about how they're impacting lives, we can hopefully work on increasing those numbers around people feeling comfortable to raise their hand and say, hey, I think I need help with this. And that just speaks to the last couple of bullet points here, which is that your life does not have to be falling apart. It doesn't have to be in shambles. It doesn't have to be severe disease for it to truly be impactful to a person's overall long-term health. And I think you all have that opportunity as providers of healthcare to employees to talk about it, to break down that stigma, to create that space where people feel comfortable saying, I don't know if I have a problem, but I'd like to talk about it and I'd like to discuss more. And then lastly, and you can go ahead and advance to the next slide. We also like to break down this idea that, folks who are addicted end up on the streets, or folks who are on the streets are addicted to a substance, and really try to break down the stigma and the connection between our homeless population and addiction. Yes, there is overlap, but they are not intrinsically intertwined. People living on the streets come from all walks of life. These are folks that we see actually frequently in our practice. We know them as fiercely independent, eclectic, and individual folks. These folks often, when they seek help from us, are not ones to complain. They get their care, they take care of their own lives, and then they often have these co-occurring health issues, which at Boulder Care, we're really grateful to our partners that we work with all the time to create referral pathways back and forth. And then most importantly, we just like to break down that stigma that folks on the street are not more violent than the general population, and in fact are more likely to receive or be victims of violence than housed people. And these folks live with incredible courage, and we get to see a large cross-section of these folks in our practice. So you can go ahead and advance. I want to take a moment to talk about the two most common substance use disorders, opioid use disorder and alcohol use disorder. Again, just making sure we all have a baseline level of understanding here. I know it's been hard to avoid opioids in the news, but just a reminder that opioids are an entire family of drugs derived from the opium poppy plant, or more recently and commonly and more cheaply, synthetically produced in a lab or something that acts like a lab to act like an opiate. And this is really where we hear or see about in the news the fentanyl trade. Unfortunately, fentanyl can be created synthetically, and that has become a burgeoning business for folks who are trading drugs into the US. So examples, include things like fentanyl, morphine, but also prescribed narcotic medications like OxyContin, Vicodin, Percocet, and Tramadol. On the flip side, alcohol, I'm sure you guys are all familiar with, but that familiar category of drugs, of drinks, including vodka, gin, tequila, all of our hard liquors, and then beer and wine. You can go ahead and advance. And then, yes, I was going to say, I think I get one more bullet point here, which is to anchor us. The reason why we're talking about these two is because these are the two substance use disorders for which we have evidence-based guidelines and protocols for management. Basically, for these two substance use disorders, I always say as a doc, I've got tools in my toolkit to treat these substance use disorders. So that is where we focus our practice right now at Boulder Care. There are other substances out there. There is disordered use of those substances, probably most commonly in my practice, methamphetamine and cocaine. Unfortunately, there are not good evidence-based treatment strategies for those medications at this time, though people are doing research. So hopefully to come. You can advance. So let's talk about some signs and symptoms of substance use disorder. I want to say very clearly, this is not a conclusive list of all of the signs and symptoms. These are examples, and these are maybe behaviors that you might see in folks. And I wouldn't necessarily go to them and say, "Hey, I saw this list, and these seem like you might have an alcohol use disorder problem." But I think these are all signs and symptoms that if you do see these patterns, opening up space for people and just saying, "Hey, how are things going?" Even calling out, "I noticed this sign. Can you tell me what's going on?" And just creating that open space for people to share what they may be struggling with is a great first start. So, some signs and symptoms early on might be, patterns of showing up late or canceling personal or professional commitments, looking more unkempt, maybe a little less put together, more tired looking. Right now in this camera, though, I'm not like loving that one because the camera isn't looking good, but no longer enjoying activities that folks used to. So things that used to bring somebody pleasure, not bringing them pleasure anymore, or difficulty concentrating, focusing, completing tasks at home, school, or work that didn't used to be an issue for someone. And then I'd say more signs of more advanced or late stage disease would be, completely withdrawing from family and friends, avoiding folks, um, truly a pattern that has gone beyond an early pattern, but to a consistent pattern of not showing up for stuff, odd or erratic behavior, feeling like people are not acting like themselves anymore. And then again, those other signs, not eating, drinking like they should be or had normally been, and then changes to personal hygiene. And then also some in later stages, certainly with alcohol use disorder, things like confusion and memory loss. Can go ahead and advance. We're good. I'll hand it back to Sarah now for a few minutes, and then I'll see you guys at the end.
Thank you, Dr. Potter. So let's shift gears and talk about what's getting better in SUD care. You can advance to the next slide, please. Some of the sentiments that we hear most often in our practice stem from this place of convenience and low barrier care. So here are two sentiments from patients, one who works out of town a lot for job and talks about how virtual care is so convenient. The other who doesn't work out of town, but is oftentimes out making deliveries 6 days a week and really appreciates a low barrier approach where doctors and peer in this case can ride along virtually with this patient. So this is our way of opening the discussion around less traditional and more innovative ways to get this kind of care. Next slide, please. And you can go ahead and pulse through the bullet points in the spirit of time. So the science of addiction care has really evolved. And you've probably heard all four of these terms before, but they're really synonymous with the science of addiction care as it's delivered today in many places. So I want to take a moment and talk about it. The first being patient-centered care. I think that we all recognize and hear a lot, both within addiction treatment and outside of addiction treatment, about the importance, the criticality of putting patients at the center. So when we talk about patient-centered care, we're talking about both the patient and their provider making decisions together in the best interests of a patient's goals. The second, harm reduction. And this has certainly been in the news a lot more recently. In fact, harm reduction was recently lauded by some of the most important regulatory bodies in our industry, and I'm happy to provide that in follow-up to this team. It's a word that's relatively new in the vernacular of some of these older agencies. And harm reduction means assisting patients on their way to achieving the goals that they set and celebrating incremental success along the way. Another way to think about it might be, for a long time, abstinence has been sort of the name of the game, and that's really changed. As addiction care has evolved, harm reduction has allowed people to pursue recovery paths that are not entirely abstinent and seek to reduce harm. Low threshold care is another example of how addiction care has evolved. And this means making it as easy as possible to get started in care and as easy as possible to stay in care. As an example, it may surprise you to know that simply being pregnant might preclude you from being involved in certain addiction treatment programs, or seeking to change your relationship with one substance but not others might keep you from being in an addiction program, treatment program. Low threshold care means come as you are, and we work together on setting your recovery goals, whether they're about one substance or more than one substance, and seeking to reduce the number of mandatory requirements that patients need to meet to stay in care. Oftentimes, those are around toxicology screening. And finally, trauma-informed care. What does that mean in the context of what we do here, in the context of addiction? That means creating a culture of safety, of empowerment, and whole person healing. It recognizes past trauma and brings cultural humility to the conversation. And that kind of care requires specific training for providers. Next slide, please. Okay, and you can, again, just click through the bullet points for me. Thank you. In the past, recovery was over-indexed on community and on behavior change, and that often took the form of AA or NA groups in community and quitting cold turkey and through the power of your sheer will. For a long time, that was what recovery looked like. And while there's certainly nothing wrong with that recovery path for folks who want to pursue it, we've come to understand that there are lots of dimensions of recovery and lots of valid paths to get there. We've talked today about the importance of acknowledging the body with medications for addiction, the importance of acknowledging the mind with not only counseling and psychiatric support, but think also about app-delivered tools like CBT and meditation and motivational interviewing that can impact behavior change. We've talked a bit about the role of peers in recovery and the importance of reuse prevention planning, about security. So this is the role that we recognize that things like housing instability, food instability, and unemployment have as barriers to recovery, and making sure we're addressing that too. And finally, navigation. Navigation means a helping hand, support, including recommendations for crisis, for counseling, etc. Next slide, please. I'm flashing up here some data from our friends over at Kaiser Permanente, who've done a study about the value of integrating telehealth and how it drives affordability. All those things we talked about on the prior slide, all of those dimensions of recovery can be accomplished through telehealth. And I want you to think about that for a bit, and taking Kaiser Permanente and its study at face value, each time an employee can access care via telehealth, they save time, up to 2 hours of work time, and can save in direct costs. And that direct cost saving stems primarily from accessing a planned telemedicine visit instead of going to the ER or an urgent care. Next slide, please. Okay, so the shift we'd like to make today is to think about where we've come from. So the evolution has been from this legacy system of care on the left, which can be thought of as primarily high cost, so primarily inpatient and residential treatment with expensive detox, stepping down to an IOP that may also be expensive, with long wait lists, oftentimes 6 to 8 week wait lists for care that exclude people with really complicated conditions or co-occurring conditions, really intensive for all patients. So a lack of individualized care and requiring this daily or weekly in-person encounter. Isolating, so little support in the traditional medical system, and sadly, pretty ineffective. So we talked about how important medication is to driving outcomes, and most programs do not offer medication for OUD. The gold standard is medication for OUD, buprenorphine, which you might know as Suboxone. So what are we shifting to? So that's where we've come from, and we're shifting to a world powered by telemedicine and virtual care in whole or in part, where we're thinking more in terms of value. So patients accessing low barrier care, they stay in care long term, they avoid adverse outcomes, and they cut costs. Making care accessible to anyone with a device, regardless of their location, their income, the complexity of their needs, making it low barrier. We talked about this before, creating a community of support, including peers, families, friends, group sessions, and importantly, evidence-based care only. So by following the evidence, we can observe a retention rate of 3 times the industry average and a mortality rate cut by half or more, up to 70% in some studies. Next slide. Okay, I see that we have about 5 minutes before the planned Q&A. So I'd like to offer Dr. Potter an opportunity to bring to life what that might look like for those who are in the audience thinking, how does this work? Virtual care for addiction treatment. I want to spend 5 minutes giving you a look at it.
Thank you, Sarah. You can go ahead and advance to the first slide of this section. I want to preface this by saying, I think what we're doing at Boulder Care is amazing. I think getting this to telehealth is fantastic. I also want to honor that I think we need all of our treatment providers. I don't think adding telehealth to the equation means at the expense of other treatment providers. And I think those are necessary and important. And I'm a family med doc who also believes that this should be destigmatized as much as possible and incorporated into primary care. But the reality is we have more patients than our current system can handle. So we'll take all solutions that can come to the table. But here's what we're doing at Boulder Care that I want to share with you all. So a patient contacts us, and we're going to call that patient Erica today. So last year, Erica discovered that this prescription pain medication she'd been using for her back pain, it's kind of taken a turn for her. She realizes when she wasn't able to access her prescription that she actually feels pretty dependent on it in order to work and care for her family. And what this paragraph doesn't go on to say is that, since being unable to access her prescription, she's actually done things that she would have never thought she'd do before, like drive to an area of town that she never thought she'd go to before in order to be able to actually buy those medications on the street. So she learns about Boulder Care when she connects with her employer, and it kind of just tells her employer what's going on and that she's really worried about what she's going to do long term. And the employer was able to kind of connect her with us and provide a handful of resources. So she calls and connects with Boulder Care and is able to schedule her first visit with a clinician for later that same day. We have options at Boulder Care for getting that first visit started. We try to get folks in as soon as possible because we do know that time between reaching out and actually connecting with a provider is really important. That's a window of opportunity that only stays open for a certain amount of time, depending on the patient. And we want to make sure that if they're reaching out to us, we're doing what we can do to get them plugged in. So she actually connects with us that same day. You can advance to the next slide. And is able to meet with a clinician like me. This is completed via an app. So the patient downloads our Boulder Care app from an app store, whether that's Google or Apple. And via that app, we're able to complete a secure video visit. So both Erica and I log into the visit. We can see each other, we can hear each other, and we basically complete the exact same type of visit I would do if I were sitting in the same room with Erica. I talk to the patient about, their medical history. We also go through a complete substance use disorder history to understand, okay, I'm hearing this about the opioids, but are there other pieces to this puzzle? And then we talk through the actual criteria for the diagnosis of either opioid use disorder or alcohol use disorder based on the DSM, which is the criteria for diagnosis of those disorders. And then we create a diagnosis. And from that diagnosis, we work with the patient to determine what treatment is best for that particular patient. So I mentioned those other care centers. Sometimes I talk through with a patient and I determine, I don't actually think this is the right or safe environment for you to be able to transition to medication treatment for your use disorder. This happens a lot with alcohol use disorder. There are certain criteria that mean you've got to be in a safe place where we can observe you and make sure we can keep you safe. So if we've got to, we refer the patient out. But a lot of times, particularly for opioid use disorder, we talk through treatment options with the patients, and many of them opt to start a medication called Suboxone, or its generic name is buprenorphine naloxone. That's a medication that binds to the opioid receptor, but in a different way than those other opioids we talked about, like fentanyl and morphine and OxyContin. Binds to the receptor in a way that blocks it and prevents people from experiencing withdrawal, and kind of stabilizes the receptor so that they're able to begin their treatment for their substance use disorder. So if a patient opts to do that Suboxone route, we talk through how to move from the opioid that they're currently using over to the Suboxone safely. And we actually send a prescription directly to their local pharmacy to pick up, hopefully that day, but depending on pharmacy hours and whatnot, it may be within 24 hours. You can move to the next slide. And then our patients get started with medication. They start their medication at home. We provide them with substantial resources, both in our app. We also try to connect them with local resources. I actually provide my patients with a lot of additional online resources as well, because there's lots of great online communities out there. And then I think you can move to the next slide. We also connect them with the rest of our team at Boulder Care. I feel very fortunate to work at a place that is multidisciplinary. Yep, we've got our prescribers, but we also have peers who are folks with lived experience who can walk side by side with our patients and offer what I like to think as sage guidance and wisdom in a way that I'm unable to provide. And so in that way, and as Sarah mentioned, we try to provide wraparound care to our patients that isn't just focused solely on the medication, but also on that psychosocial healing. Can you go ahead and advance? Trying to make sure I leave some time for questions. This is a common question that we get. We do complete monitoring. That's a component that is somewhat of a gold standard of care of substance use disorder in the United States. We complete that via a test that is sent to the patient's home. So again, they're able to complete things from home. If they don't have an address where they can receive mail, we have some other workflows that allow us to accommodate those patients. But we do monitor that patients are taking the medication that we're prescribing for them. Go ahead. And then most importantly to me, I feel like we create a space where patients feel like they can reach out when they need help. Whether that be, I'm on this medication and I just don't think it's covering enough. It's not providing enough coverage for my withdrawal symptoms. Or it might just be, I had a crap week. I had a crisis within my own world, and I just need to talk to somebody. We've got those different levels of support for people to be able to access. And in a way that they can do it. I share this all the time, but my patients see me in all kinds of places, but it works for them and they're able to stay in care. So whether they're calling me from the freezer at Domino's, which is the only place where they can get some privacy on their work break, or they're calling me from home, I'm just happy that they're able to connect and able to stay engaged in care. As a provider who's done this care for many years, the greatest part about this is getting to see people be able to stay engaged. That was such a frustrating part of my practice when it required them coming to my office, maybe waiting an hour in the waiting room by the time they were pulled back to get seen. This tends to be a way for people to access care and be able to balance all of those other obligations in their life, like work, school, kids, you know, the stuff we all deal with. All right, I think that's the last slide, but you can advance just to double check here. Perfect, we're back to a poll.
Thank you, Dr. Potter and Sarah. It's so wonderful to have both of you here bringing all of this information to us. Let's, yeah, there we go. There's the poll. So which of the following would help you to have conversations with your workforce about SUD that you're not having today? Please click one or all, whatever. You're able to choose more than one option here. And so while you're all responding to this poll, we had some fabulous questions in the Q&A, and I want to start with the one that Renee asked, which is, how does the program handle dual diagnosis individuals with mental health issues? Because I think that this is foremost in most employers' minds.
Sorry, I couldn't get to the unmute button for some reason. So at Boulder Care, we do provide care for dual diagnosis. At this point in time, what we try to do is short-term management of concurrent mental health disorders like depression and anxiety. We try to work to manage that for something like 3 to 6 months while simultaneously trying to identify a concurrent mental health provider. But that is certainly an area where we continue to work on expansion of services. We have many psychiatric nurse practitioners at Boulder Care, so we're hoping to create more of an internal referral system eventually. But right now we do some short-term management and then a lot of collaboration to get folks connected with longer-term care.
Fabulous. What's your success rate on that with that connection and getting them in? Are you aware, is there a closed loop there so that you're aware of, time till appointment and things of that nature?
I will be honest, it's highly variable. And we do operate currently in 5 states. Sarah may be able to speak better to an actual rate. But I will say in my experience, we actually have more success in places like Washington and Oregon, where we are sort of rooted, the companies, and we've got a lot of folks that are there. So we have a lot of folks on the ground there that are able to make those connections. And we do try to keep, that circuit as closed as possible with the patient permission to have that closed circuit with their other providers, which is, sometimes it makes a lot of sense, and other times it understandably does make sense when patients want to kind of say, I'm just going to get my addiction medicine care from you all, and I need it to stay kind of quarantined, for a better word. There's probably a better word for it, but kind of siphoned off for confidentiality reasons.
Okay, good to know. Michael Garrett's asked some fabulous questions regarding equity, but before I get to those, I want to just kind of highlight some things that came out of this for me, which is 70% of the workforce is living with some substance use disorder, and only 24% of them are receiving any kind of assistance, right? And then the cost of care for those not receiving is 6 times as much as your average person, non-SUD. And so that's pretty astounding. And it seems to me that there's tremendous opportunity, right, as providers and also as purchasers of healthcare to expand availability of services, right? And I think that Boulder is not about substituting, right, eliminating other services, but augmenting what's already there. But I want to highlight So Michael asked about people with vision loss, hearing loss, and limited English proficiency. And so Sarah did respond saying that you do have interpreters, specifically ASL interpreters, and you also provide a language line. So I'm assuming that, and just correct me if I'm wrong, we're at the top of the hour, that you loop in an interpreter. So everyone's on the line together.
That's correct, Denise.
Yeah, yeah. And then the other he asked about is the broadband. And those capabilities and yeah, if you have patients with limited access for any kind of device, right? To any
Yes,
use of technology.
common problems.
Yeah,
And for
yeah.
lack of device, we do work with the Affordable Connectivity Program, the federal government program that provides devices to those who are eligible. Our preferred partner is Sano Health. For patients who have a device, but maybe they don't have broadband in their home, we rely on our community liaisons, our team of people on the ground in the markets we serve to identify public places where those who are struggling with broadband can come and have a secure visit. It's actually a really big burst of activity for us in Southern Oregon right now. So I know that's not top of mind for this Washington audience, but know that that is how we go about it.
Well, and we do have employers with employees in Oregon, so we're not just limited to here. So that is good to know. And then Michael's final question, we'll answer that offline. We'll include the response in our follow-up email with our presentation and recording for everyone. But want to thank everyone for being here with us today. Appreciate the last response to the poll. Thank you for that information. It's very helpful for us to be able to see what additional resources and support that you could use. So have a good day, everyone. Dr. Potter and Sarah, thank you so much for
Thank you. Good afternoon.